Certainly an honor to be here. As Kim mentioned, I work now at the Emory Rowland School of Public Health and have worked quite a bit in international settings, both in Africa, Western Europe, and also in the Middle East, and most currently work very intensively with the Kingdom of Saudi Arabia, which one could arguably make the case is probably the most important country to the United States in terms of a diplomatic partner. And as you may well know, maybe you're sensitized to the current outbreak of the MERS coronavirus, which is occurring now, which originated in Saudi Arabia, and the fact that yesterday was Eid, which is the end of the Hajj. The Hajj, of course, is a convocation of Muslim faithful who make a pilgrimage to Mecca and the surrounding cities as a part of their religious obligation. Over 2 million people coming from over 140 countries for a very short period of time and then going back home. So there has emerged in the course of science, I'm an epidemiologist, we look at population medicine, we study the occurrence of disease in populations, that there is a concept called mass gathering medicine. There are unique elements of public health that occur when large people's groups convene. Could it be a soccer match, or for that matter, in the United States, it could be a large football game. But there are certain specific elements of transmission of disease that occur uniquely in these settings, and especially during Hajj. And there are other religious events that occur in Saudi Arabia as well. So we have developed a very close relationship with the Ministry of Health in Saudi Arabia. The minister came to Emory 3 years ago and signed an MOU with our university. Our intention here is to build peace through building friendship, collaboration, and studying science around common global best practices, if you will. So the minister, with our dean, Jim Curran, who's one of the first epidemiologist to investigate the AIDS epidemic here in the United States. We have a very close collaboration. We are training their future Centers for Disease Control. The King instituted last spring a CDC in Saudi Arabia, and so our program at Emory is training those mostly physicians, but there are other nurses and other public health practitioners who are working on their Masters in Public Health at Emory. So we have 28 students right now at Emory working on their MPH. So we support the students in terms of providing a facility. We pick them up at the airport. This is, for the most part, the first time for them to visit the United States. So we help their families get situated into life in Atlanta with apartments. There's a private Islamic school in Atlanta, making sure that their families know how to adjust and can get driver's licenses and be able to come to class. So I live in Atlanta, and if I go up to I live on a high-rise condominium, and go to the east, go out my east door, I can see Stone Mountain, which is about 10 miles away. And oftentimes reminded of Dr. King's speech that he made referencing Stone Mountain and the importance of social justice. So this is a very appropriate forum for me to talk about a component of global social justice. And it has to do with Saudi Arabia, with Islam, with the role of the WHO, etc. And so I'd like to sort of take you on a journey here, basing this on the facts as they stand around the MERS coronavirus. And I think that Dr. King would be pleased for us to be discussing these issues around global social justice. First of all, I'd like to sort of orient you a little bit to talk about the international health regulations. If you're not familiar with those, and I'd like to review both the authority and the obligations of national ministries of health, including our own HHS or CDC, which is an operational division of HHS, and the role of WHO for public health surveillance. Because the international health regulations are an agreement that collectively the 192 member states have set upon to discuss how we share information around public health issues and what our obligations are. So let's talk a little bit about what we'll call public health surveillance, which in essence is the detection of outbreaks, the response to outbreaks, and the appropriate national obligations in that regard. And in the revising of the IHRs, you may remember the SARS epidemic, which occurred in the early part of 2003, 2002, which really prompted an initiation of the revision of the IHRs. And you remember the scare, the global scare around SARS, and how it impacted not only morbidity and mortality, the number of people that died and got sick with SARS, but also the economic consequences of that, especially to certain countries. So there are some issues here around detection, the transparency of the exchange of public health information, as well as the vaccines that are produced and the equity around vaccines that are produced during these epidemics. So the global community recognized that we live in a world where there is a tremendous number of emerging and re-emerging infectious diseases that have occurred. Something like 90% of human illnesses come from animals. And it's the concept of One Health has emerged, where you have the linking of veterinary public health with human health. We're working in Africa, for example, looking at One Health initiatives, where we link veterinary medicine and also veterinary laboratory with the human health and human medicine. That, in addition to the newly emerging issues that have prompted the fact that we do live in a flat world, and that microbes, viruses, and bacteria do not know borders. And so it's incumbent upon us as a global community to develop the sort of collaborations and the governance model that would allow us to work together. That, combined with the fact that 3 weeks ago I was in Riyadh, in 2 weeks I'll be in Cameroon. So we live in a world that's where communication systems are very rapid. Most of the pilgrims who come to Hajj now come by airplane, as opposed to a century ago when they came by ship or over land. So when you come by airplane, you reduce the travel time, obviously, and so the impact of an occurrence where you are in Mecca, literally elbow to elbow with 2 million people, where the transmission of disease can occur so easily, and you go back home, you're back home within a week, and the potential impact of that on the home countries becomes really very important. So the global community, leadership of WHO, established a revision in the international health regulations, which was embodied a new strategy called global health security. You hear now, we work closely with the Department of Defense here in Washington, who has what's known as the DTRA, the Defense Threat Reduction Agency, which is responsible for not only chemical and radiologic events, but also biologic events. So we work with the DoD as a new partner in global health security. This is implemented through a new approach, which is, I think, very much in line with the approach that Dr. King advocated and would advocate in today's world, which is governance, meaning sitting down, using what Joseph Nye calls smart power, which is our diplomatic approach now, where we use our leadership role in convening and bringing people together to discuss common issues. My grandmother used to tell me that I have 2 ears and 1 mouth, so I should be listening twice as much as I talk. And rather than my way or the highway, it's more of a convening authority of leadership, which is the solution. And that is a respectful way to deal with people. And so that's part of what I like to talk about today. So the SARS outbreak in 2003 really served as a tipping point and accelerated this movement to revise the international health regulations, which were done so and put into place in 2005. The United States approved or bought into the IHR with a reservation, because you remember in our Constitution we live in a federalist form of government, and according to our Constitution it's the governor of each state who's responsible for health in that state, not CDC. It's not the national level, but it's the local level. So there is a reason why we made our reservation, meaning reporting of what would be called public health emergencies of international concern, like the 2009 H1N1 pandemic was reported by the United States to WHO because of the reporting agreements between the state health departments and the national level. So the IHR is a legal binding document that aims to assist countries to work together to save lives and livelihood that are endangered by the spread of disease and other health risks. We work with the WHO office in Geneva to help countries fulfill their obligations of the IHR. That's why I'm going to Cameroon in 2 weeks to develop and pilot test a tool, a costing tool, that allows the Ministry of Health in Cameroon to evaluate how far they are along in fulfilling these obligations. It also supports certain confidence in the global health community about notification of these emerging problems. So the purpose and scope of the IHR is to protect, prevent, control public health responses to international spread of disease. So we have this in place now, and it's being actively an active governance policy. And this revised role of the IHR granted certain authority to the World Health Organization. First of all, to make public health-related recommendations to member states, including the United States, and also to travel companies around specific global threats, to obtain independent advice regarding IHR implementation, that is, to confirm what would be called a public health emergency of international concern, and there has been one that's been officially reported by the Director General. That was the 2009 H1N1 influenza pandemic, which, as you know, began in Mexico. It was diagnosed and reported in the United States, etc. Also to gather information from non-official sources in addition to the official notifications by the member states. So there's a respect for national sovereignty built in to the IHR. Every nation state has its own responsibility to detect and to investigate outbreaks of disease. And there are obligations of member states in this, meaning that in the United States, for example, we have a role. We're obliged to notify WHO of events that are judged to be public health emergencies of international concern. Every member state has the obligation to do this. Every member state has the obligation also to develop and maintain these core public health capacities, including public health surveillance. And right now we're not doing very well on the global stage, which is why WHO and our team is working hard with them to try to identify the gaps and the impediments to achieving full core capacity, especially around surveillance. Also, the national level establishes a national focal point, which is here in Washington at the office of the Secretary Sebelius at HHS. But I'll ask the question, what about the authority of a member state to its citizenry? These are important questions that go to the core of my talk today about social awareness. What about the authority of a government to its citizenry, and what about the obligations of WHO? Sort of the reverse of what I just presented the IHR talks about. So we have in the United States a very effective group called the Council of State and Territorial Epidemiologists. Those are the state epidemiologists in each state, given the authority by the governor to do detection, do public health surveillance, do response efforts. And so, according, as I mentioned, in our Constitution, the powers have been delegated to the state for public health, not at the national level. So CDC, and I spent 20 years there working in global health and in informatics, has no authority for enforcement of public health as stated in the 10th Amendment. But the CST works actively in collegial way with CDC to do notification of disease. There is a recognition that it's useful and helpful, mutually beneficial, if you will, for each state to report to the national level. And you see in the MMWR, the Morbidity Mortality Weekly Report, every week an occurrence of disease in each state. That's a voluntary reporting system that the state epidemiologists have agreed upon. So this collaboration at the level of the state epidemiologist has enhanced trust. They meet every year, they talk about what to report, they talk about the issues they've got. They come together, if you will, at a scientific level and a policy level to discuss how best to find mutual benefit and collaboration. So it's a model, if you will, for the global level. So we can be proud of the work that the CST has done in the United States. And certainly they do promote effective use of public health data. There are certain mission elements to the CSTE. They support public health surveillance and training through public health practice through training, capacity development, etc., develop standards of practice as a collaborative scientist, and advocate for resources. So this group, the CSTE, is a good model which we use in the United States for collaboration to build trust and to enhance transparency that could be a type of a model at the global level. And I'm going to make the case that there is a need for this. So let's sort of move to the current situation and talk about a concept called viral sovereignty and its impact on global health security. Viral sovereignty is a new concept, actually, and it really is I'd like to give you two case studies to talk about viral sovereignty. The first case study is the avian influenza in Indonesia. You may remember that in 2007, Indonesia was at the forefront of H5N1 avian influenza epidemic, and the Minister of Health at that time, Dr. Supari, declared on February 15, 2007, that Indonesia will insist on a material transfer agreement before sending any strains of virus to foreign laboratories. So I'm getting at it, using a case study to discuss with you the value, in fact, the requirement of developing better global governance to be able to control future pandemics. Dr. Supari stated that we agree to send the virus to WHO with new conditions or mechanisms. Now, there's a reason why she stood up and said this. And so I'd like to make the case that, which is in her book, that there were certain frustrations that she experienced as the Mistress of Health in Indonesia. The first is that vaccines made from virus originating in Indonesia would really be of no benefit to Indonesians if the virus was left the country. The reasoning behind that is that if vaccines were manufactured abroad and priced, it would be priced out of reach for most developing countries. Plus, the vaccine stocks, which would be bought up, if you will, by developed countries who had not experienced even one case of avian influenza. So you can see her concern that if a virus that originated in Indonesia, that left the country, was patented, manufactured, often, for the most part, the vaccine would not be used in Indonesia because of the pricing of the vaccine, plus the fact that most of it would be bought up by rich countries. So here is laying the foundation for social injustice. And so I really compliment her for her courage. In The Lancet then, in February of 2007, there was an editorial which basically reflected on this point, and that they stated 6.2 billion doses of a pandemic vaccine would be needed to respond to an epidemic like this, but that the world could only produce 500 million doses, so that most developing countries would have no access to vaccine. Now, what would you think Dr. King would think about that, right? So you see immediately that this social injustice occurring here between those who have and those who have not, if you will. In the Washington Post then, the late diplomat Richard Holbrooke and Laurie Garrett talked about, coined this term called sovereignty, virus sovereignty. So that this was an editorial that was written in 2008. The deadly viruses are the sovereign property of individual nations, and they viewed this as a threat to the United States. And that they stated that Indonesia had openly defied the international health regulations. I think that now we would argue that they were not actually correct in their editorial, because I would make the case that national governments do have an obligation to their citizenry. In fact, Canada awarded its vaccine contract to a Canadian company because, if awarded otherwise, a foreign government may restrict exports due to vaccine shortages. So you have now the situation where in the world, for example, an Australian manufacturer was told it must fulfill the government's domestic needs before exporting vaccine to the United States. And in September 17th of 2009, the United States pledged to donate 10% of its vaccine purchases to WHO. But later, about 6 weeks later, Secretary Sebelius stated that the United States would not donate H1N1 vaccine as promised until all at-risk Americans had access, because production problems had created shortages in the United States. So I would make the point that in the absence of governance and in the presence of shortage, nationalism trumps altruism. It's clearly the case. So this points out an issue that we have to deal with in the global community. So Ministers of Health, Zipari's claims were really supported by current international treaty. The Convention on Biological Diversity recognizes that the authority of a member state over natural resources and access to genetic materials, and that viruses constitute genetic materials, as explicitly stated in the Cartagena Protocol on Biosafety. So indeed, she was correct that if a virus originates in Indonesia or in Saudi Arabia, that virus belongs to that country by virtue of treaty. Now that belonging also has certain obligations to it. So I'd like to now take you to case study 2, which is the current situation with the MERS coronavirus and the Kingdom of Saudi Arabia. Then I'm going to bring you back to our program, because the way that I believe, at least one way, of developing effective trust and transparency is through education and collaboration and the sort of communication that occurs in programs like we have at Emory, where we're working with 28 Saudi Ministry of Health officials, working with them, training them. They're doing their thesis work on data from Saudi Arabia, so that we work and develop this sort of common understanding about what the global best practices are. We're really building what I would call global public health diplomacy, which is building peace through collaboration and friendship and respecting the sort of authority and obligations of each of our countries. Let's talk a little bit about what has happened with the current MERS coronavirus. You may remember that it's an ongoing SARS-like coronavirus outbreak that originated in the Middle East, officially named MERS coronavirus, and this outbreak is currently happening now. This is a situation. I was in Riyadh at a large global mass gathering medicine meeting where officials from all over the world gathered to talk about this outbreak, including WHO and our own HHS and CDC. This is from the WHO website, where epidemiologists think about how you define a case. Probable cases have been defined, confirmed cases, etc. The sort of science around outbreak investigation has been developed. And this is the current WHO website. And so as of October 14th, interestingly, 2 days ago, Dr. King was awarded the Nobel Prize 47 years ago, I believe. So it's a celebration of the holiday in part of his award. That there are globally 138 confirmed cases of MERS coronavirus, with 114 in the Kingdom of Saudi Arabia. That there's a very high case fatality rate of over 43%. A significant number of people who come down with the disease die of this disease. And I'd like to show you a clip that was from the Ministry of Health here real quickly.
Statistics, I see 49 cases, but 27 deaths. In other words, quite a lethal virus, this one.
Yeah, it's a bit of a bias because we are only testing people who are actually in the hospital with pneumonia. And these people tend to have the severe form of the disease. Now we did not extend our investigation to the community, to the family members who are not showing severe symptoms. So we are only testing the very severe cases, and they are more likely to have a lot of chronic diseases and more likely to die from any infection, even if it's not as severe as the current infection.
So there might be a statistical bias there because not all cases are reported as coronavirus cases.
So Dr. Asiri, who you just saw in the clip, is my colleague, and he works with us in identifying candidates that would be eligible for matriculation at Emory in our program. And of course, so I'm making the case that education builds the opportunity for us to collaborate and to work on these issues together. There was an article that Dr. Asiri authored in the very prestigious New England Journal of Medicine about the description of the epidemic in July, and so there's a very active academic effort to try to describe and to work with the global community on understanding this outbreak, understanding the nature of the virus, etc. So we have now then, we're now globally at the end of the Hajj, which I mentioned to you was this important mass gathering. So there was great concern early on about whether or not there would be a spread of disease during Hajj. And the fact is that the Hajj has been safe as far as we know today. In fact, there have been very few cases that have occurred as a result of the Hajj. So WHO did not advise any special screening at the point of entry, nor recommend any travel or trade restrictions. And the Minister of Health himself, in fact, has been very actively involved in detection of disease. So there have been no cases of MERS virus among Hajj pilgrims so far, according to the Ministry of Health, which is a very great blessing to the global community. Because if the occurrence of spread, which is transmission, of course, is by respiratory droplet, just like the flu. So you have sort of when people are coughing and sneezing and so forth, you have the opportunity for the virus to spread quite quickly. So there were no cases during the holy month of Ramadan in Saudi Arabia. So, the way that we develop the sort of trust and transparency is by respecting the Saudis' authority as a national government to do this work and also to help them on the science side. So there's an intense effort now to understand the science around MERS coronavirus, whether it's communicated by camels or if it has bats are a part of the reservoir for this virus. So there's intensive laboratory investigation, genotyping studies that are being done in Columbia University here, and also other parts of the global community. So and this is, of course, is the Ministry of Health's website about coronavirus. So there's a modern way of looking at health communications. Those of you, I know we've been watching the Arab Spring, and I was in Riyadh, in fact, in February when the Arab Spring really began in Egypt, and you realize that what gave the energy to this was the communication that occurred using social networking among participants. And it was like under the cover, the government wasn't so much aware of it. And, if you're wanting to go out and protest an injustice, you take a great risk to go out into the streets. But if you know that your colleagues and your friends are going out, that gives you much more momentum and energy to go out. So social networking, Facebook, SMS messaging, etc., really provided the fuel, I think, for the Arab Spring. You cannot hold communication back. If you look at each one of the instances of, including what's happening in Syria, the first thing the government tries to do is to control the communication or control the message, and they can't do it, so it's not a successful strategy anymore. So we try to do the opposite of that in terms of health communication. I would say that CDC has done a great job, especially in 2009. Dr. Besser, if you remember, the pandemic would be there every day. This is what we know, this is what we don't know, and this is what we're trying to find out. And that level of communication of the circumstance eased everybody's mind, developed trust among not only the people but professionals. If you don't do that, I teach oral communications at Emory, and part of my communication is about media relations. If you don't, the media are like lions. If you don't feed the lions, they will find their own food, so to speak. There will be an inventing of certain messages, which are may not be the truth. So there is a global blog at The Lancet that's hosted by Dr. Ali Zumla, who's a very distinguished professor at the University in London, about this, to talk about social justice, because I'd like to describe what happened in this circumstance. So then in June of 2012, a microbiologist who was in a private laboratory in Jeddah, Saudi Arabia, discovered the virus, if you will, or isolated this new virus. And instead of doing what his legal obligations were to notify the Ministry of Health, like if it occurred here in the District of Columbia, the laboratorian would be obliged to notify the state epidemiologist here to go through the official reporting system. He sent the virus out of the country to a private laboratory in the Netherlands for patenting purposes, which meant the money that would, presumably the money that would be made by producing the vaccine. So in some senses, the virus was stolen from the country, and for a period of time, there was not, for almost 3 months, the Ministry of Health was not notified about this circumstance. Really, it's a tragedy because it was a violation of the national sovereignty, the responsibility of the Ministry of Health in Saudi Arabia to do the detection, investigation, and the reporting. So instead, there was some concerns about publishing this work, and the virus subsequently published his work in the New England Journal of Medicine. So he, out of a sense of trying to get a publication out of it and to get the isolate patented, it put the world at risk. So the virologist failed to comply with his contract. If that happened in Georgia, I mean, you would never quit hearing the screams from Dr. Tom Frieden, who's the director of CDC, and from HHS. People, you can imagine if a virus was taken from the United States out of the country, was not notified at the official health authorities for over 3 months. I mean, my Emory sits directly next door to CDC. I would never quit hearing the screams that came from the office of the director at CDC about this. So this was a violation, if you will, of the national authority. And I'd like to then take this as a point of social justice to discuss with you this important issue, because this impacts global health security. And that I'd like to ask the questions, what are the authority and obligations of the issue involved here? First of all, the medical and laboratory staff have the legal obligation to report to a Ministry of Health, whatever Ministry of Health that is, new conditions that may be a public health concern. You may be aware that Lyme disease, for example, in the United States, West Nile virus, those new emerging pathogens were identified in the United States by laboratorians or by epidemiologists, and the official notifications stream was made. It's a legal obligation. Every state has this requirement, and medical students are taught this, but not very well. And they actually, when they agree and sign their contracts, they're obliged to report through their official authority. Consequently, the Ministries of Health, including CDC, has the duty, really, to investigate, contain, and prevent future cases. So this whole event was not fulfilled. And this is the paper that was published in the New England Journal. When I was in Riyadh 3 weeks ago, the editors of the New England Journal of Medicine, the editor of Lancet, and the editor of JAMA were at this meeting to discuss these issues about intellectual property and what should the journals do to sort of protect the authority of a respective Ministry of Health, but also value intellectual property and the sort of importance of new findings, etc. So, the history of this is now pretty much apparent. It's over a year. But the ownership issues and delays are important because this private laboratory defended their action of taking the virus from this microbiologist and stating that every laboratory would have the right to the virus if they complied with certain safety criteria. But the reality is that this is not working, and that there are laboratories that have problems getting the virus. And in fact, US CDC, the National Micro Laboratory in Canada, the WHO, have not been able to get the virus because of legal delays. So you can see the issues around this point. So my colleague, Dr. Ziad Mamesh, who was here in Washington August 18th to give a presentation, to meet with HHS officials, and to give a presentation not far from here, sponsored by University of Pittsburgh Medical Center, to present the current situation with the outbreak. stated at the WHO meeting last May their concerns. And in fact, the Director General, Dr. Chan, voiced her concerns, stating, tell your scientists in your country because you're the boss. You're the national authority. Why would your scientists send specimens out to other laboratories on a bilateral manner and allow other people to take intellectual property rights on a new disease? Further, she stated that, oops, go back real quick. She stated, making deals between scientists because they want to take intellectual property, because they want to be the world's first to publish in scientific journals. These are issues we need to address. No intellectual property will stand in the way of public health actions. And of course, we agree with her totally. And it points out this current problem in our global social justice system, if you will. So I'd like to close with what I think might be a way forward. I know Dr. King always had marching orders or an call to action, if you will. And I think there is one here for the global community. First of all, I think that to answer the question, what are the obligations of WHO to the global health community, is a very important question to answer. There is a framework for pandemic influenza preparedness, which was adopted in 2011, the objectives of which were to strengthen the pandemic influenza preparedness and response, etc. This is a good milestone in global governance, but it's not the goal line. It's a step forward, but it's not the end stage governance document. The benefits of this document are that there is a virus sharing system that is proposed, requires industry contributions to a surveillance system at WHO, encourages laboratory not to seek intellectual property rights over biological materials. It facilitates industry access to biological materials and supports transparency. But it has enormous limitations. That is that the framework does not direct developed member states to provide benefits for developing countries. So it's not a policy document that has any type of teeth in it. It's not legally binding. It reinforces a global norm but does not alter the status quo, if you will. And it avoids setting normal norms for intellectual property. So there is a step forward in this regard, but there needs to be more work. And I think that when we think about balancing authority and obligation, first of all, WHO is not a policing agency. It doesn't really have teeth in its mission. There are no enforcement mechanisms to ensure IHR compliance. It's really an agreement that all the member states have bought into, including the United States. And success of it rests on two components, trust and transparency, as well as an understanding of the obligation and authority among member states, among WHO and the global community. And that successful detection, investigation, etc. should be a source of national pride. It should be something that every member state is proud in doing. In fact, one could make the case that on my iPhone there should be an app, a public health app. And I should be able to go to my public health app and determine what are the current health conditions in China or in South Africa or in Indonesia, for example. That this type of public health information is human right, really, and it should be available to everyone based on the protection of human subjects issues, etc. And that vision has not been fulfilled yet. So we have a way to go. And I would say that we have to respect intellectual property. I'm a scientist. I publish. It's a part of my obligation as a faculty member. But we need, as was stated by Dr. Storer, we need people to share data and set aside Nobel Prize interests or their desire to publish articles if we're going to move forward. There has to be a respect for global security in this way. However, the SARS outbreak sparked two races. One was to sequence the genome of the virus because it meant money for the vaccine companies, and the other was to publish the work as quickly as you could because it meant intellectual property for the individual scientists. So that I would make the case that the overprotection of patient patent rights may ultimately deter innovation and stifle biological research. In fact, I would like to compliment the Chinese Ministry of Health, who simply gave away the samples of H7N1 as did Mexico. So it became open source. In other words, if a virus like this is discovered in a host country, it's not only a national treasure and belongs to the country, but also is a global treasure. And so to make it open source so that it can be studied, investigated, vaccines can be produced is very important. International law for patent seeking are very complex and outdated, something that needs to change. In fact, recently the U.S. Supreme Court ruled that isolated human genes cannot be patented in regards to these 2 genes that were reportedly patented by Myriad Genes. So national products these natural products have a certain uniqueness to them. There also needs to be an equitable sharing of vaccines and medicines, and I think that Dr. King would agree with this. Laurie Garrett also wrote in May of 2012 that there is a problem, there's a health crisis concerning affordable access to life-sparing medicines and safety and reliability of those medicines, and that the G8 and G20 countries should take the lead as a matter of urgency to promote collaborations among national safety regulators so that there would be a better and more responsible medicine chain, if you will, that's no longer transparent or readily traceable. Counterfeiting of medicines is a real crisis in the global world today. So in conclusion, then, she stated that the supply decoupled with patent protections and tackled through collaborative relations was one solution. So again, what are the obligations of WHO to the global community? I believe we need more trust to enhance transparency through improved global health security. And that there are specific statements. This is one of all the forms of inequality. Injustice in healthcare is the most shocking and inhumane, which Dr. King stated in a speech in 1966. So the recommendations that I would make to improve trust include establishing ethical standards for public health surveillance, developing data stewardship agreements beyond the international health regulations, to train in global best practices for health communication so information is communicated quickly, accurately, and is in an appropriate format, and to update the international patent laws and to address this creative tension which lies in the peer-reviewed literature, where we have the respect on the one hand for intellectual property, but the requirements for transparency are also equally respected. So, our work at Emory is all about transforming public health surveillance so that public health information is available where it's needed, when it's needed. So I'd like to thank you for inviting me very much to this, and I'm happy to field any questions.